system today. So, here's the structure of the female reproductive system. Basically, the primary gonads, the equivalent of the testes in the females will be the ovaries. They'll be, hold on, let me get my formula. It's this structure here on the side, and the structure is over here on the side. And they're suspended in this particular pelvic cavity by a bunch of ligaments and connective tissues and things like that, right? And then the other structure that forms from your Mullerian duct, you guys remember, without the MIF, without the testes and all that stuff, the Mullerian duct starts to develop, right? And the Wolffian duct starts to regress. So the Mullerian duct forms what we call your fallopian tube, which has multiple parts. So this long tube right here, this is your fallopian tube. Up here or down this portion right here, that's right next to your ovaries, that's a portion of the fallopian tube called the fimbriae. So finger-like projections, basically. And that's an enlargement right here called the infundibulum. The infundibulum then basically continue to narrow, and along the way, the major pathway along the fallopian tube we call the ampulla, right? And then it narrows into this area called the fundus, and eventually into this portion. Not the fundus. It just narrows into this particular area called the uterus. The uterus is a muscular organ. It looks like an upside down pear, right? It has this bulbous portion up here called the fundus of the uterus. The rest of this uterus is basically the body of the uterus. Okay? And then the uterus then narrows down into this area called the cervix, and then out into this particular receptacle area called the vagina. Okay? And then in the uterus itself, you have three layers. You have the outermost layer called the perimetrium. The middle layer of the uterus is called the myometrium, which contains a huge amount of smooth muscle. And then the innermost layer is this layer here, which grows extensively during different cycles and stuff like that. We call that the endometrium. Okay, so endometrium is the inner layer, myometrium is the muscular layer, and then perimetrium is the outer layer of the uterus. Okay, and then narrows into the cervix, and then basically exit out into the vaginal canal. Okay, so that's the female reproductive system. This is a sagittal view looking at the female reproductive tract or female reproductive organs in relation to other organs. So the female reproductive organs, so here's your uterus, here's your ovaries over here, here's the fallopian tube connecting to the uterus. This is the cervix, basically this is the vaginal canal, right? Now if you look at the pelvic opening, there's three areas here. So anterior to all your reproductive organs will be your urinary bladder and the urethra, which is part of your urinary system, so exclusively part of the urinary system, right? For the female urethra, it doesn't share any pathway, unlike the male urethra shares pathway between urine and semen itself, right? So for female urethra, relatively short, straighter, and is exclusively part of the urinary system, okay? And then behind the reproductive organs, you have the rectum, and then the anal canal, which is part of your digestive system, okay? And there's three openings, obviously. There's an anus out here, there's a vaginal opening here, and there's a urethral orifice there. So therefore, because all of these organs are in close proximity, it's very important that we teach our younger female, individuals, like younger female girls, when they go and, let's say, go to the restroom, when they urinate or they defecate, they should wipe from front to back, right? Never back to front. And especially if they defecate, if they do wipe back to front, sometimes inadvertently, they can introduce fecal material from the rectal area into the vaginal opening or even into the urethral opening. Now, if fecal material enters the vaginal opening, it's not a big deal because you can wash that out. It's relatively more external than anything else. But if it enters the urethral opening, because the urethra in the female is relatively short, there's a very high chance that the bacterial colonies within your fecal matters will start to colonize that area. It starts to grow. And because it does that, it now causes some degree of inflammation, and we call that a urinary tract infection. Okay? And that urinary tract infection oftentimes will ascend into the urinary bladder, causing high degree of frequency, urgency, and also pain upon urination and things like that. Right? So teach your female individuals to basically wipe appropriately. Now, it's not only the younger female patients that encounter these kind of issues called urinary tract infections, because in the adult female individuals that are sexually active, oftentimes after sexual intercourse, because there's a lot of mixing of like fluid everywhere, like from different areas of these particular structures that are right next to each other, sometimes you can have a lot of fluid coming from, you know, whatever, semen, vaginal secretion mixing and then being deposited into this urethra. So therefore, you may also increase the risk of having a urinary tract infection. So because of that, we also advise our female patients, if they're sexually active, to urinate after sexual intercourse, right? After coitus and things like that, right? So that's just to sort of like, you know, be cautious of the fact that you don't want any deposits of bacteria to build up within the urethra itself. Because the urethra is not a very long section or long structure within the female reproductive organs. And so you don't want any kind of bacteria to kind of, you know, start to grow and infect that area. Okay? Otherwise, it's, you know, very painful and uncomfortable, obviously. All right. So now, you guys remember all of that progression, right? So very early on in development, let's say you have an XX embryo. That XX embryo, since it doesn't have the Y chromosomes, it does not have the SRY gene, and without the SRY gene, there's no TDF, there's no testes determining factor. If there's no testes determining factor, the primordial gonadal cells do not develop into anything, because those particular structure, those factors, those proteins, whatever it is that's secreted, it's going to stimulate those cells to develop into the testes. In the female individual, since there's no TDF, none of that thing happens. So therefore, that primordial gonadal cells, that massive cell, stays undifferentiated for an extended period of time until this female individual reaches the age or the developmental age of about, I don't know, within 3 months or something like that, right? So toward the end of the first trimester or even toward the second trimester of the embryonic life of this individual, then those gonadal cells will start to form ovaries. Once the ovaries are formed, all of the cells inside the ovaries are known as the oocytes. So collectively, all the eggs inside the ovaries are called the oocytes. But those eggs starts with a stem cell, and that stem cell is referred to as the oogonia. So immediately, once that ovaries is formed, all of these oogonia starts to go through mitosis. All of them go through mitosis. So none of them remains after this mitosis, and all of them becomes what we call primary oocytes. Okay, so again, keep in mind that during this mitotic phase, right, one of this oogonia becomes 2 primary oocytes. And each of these primary oocytes is still a diploid cell, so still has all of the chromosomes that exist in both mom and dad combined together. Okay? Now, each of those primary oocytes begin to go through meiosis 1. But immediately, all of them are stopped at prophase 1. Okay? So all of whatever number of cells, and at that particular point in development of the female embryo, very early on, there's this roughly about 7 million primary oocytes collectively in both ovaries, right? And all of them goes through meiosis 1, but all of them are stuck in prophase 1. And we call this meiotic arrest, okay? So the primary oocytes, as they go through this meiosis 1, they don't even complete it. They don't even complete the first phase of meiosis, which is prophase 1. And they're stuck there until that child is born and until that child reaches the age of puberty. So all of the primary oocytes in that female child are all stuck in prophase 1, okay, until she reaches the age of puberty. Now, of course, by the time you're born, the number of oocytes that are still inside the ovaries decreases drastically, because throughout time, as some of these eggs, basically as the body starts to grow, a lot of these primary oocytes gets resorbed and gets destroyed. Okay, so that 7 million that you start out with, by the time you are born, it decreases down to about 2 million, right? And then by the time you reach the age of puberty, the female individual, the amount of primary oocytes that she has now decreases down to roughly about 400,000 to 500,000. That's it. So you start at 7 million by the time you start to form your ovaries, and then by the time you're born, that number decreases down to about 2 million. And by the time you reach the age of puberty, which is basically roughly about 10 years after you're born, that number decreases down to roughly about 500,000, like 400,000, right? And throughout the lifetime, the reproductive lifetime of any female individual, she will ovulate roughly about 400 of those 400,000 oocytes. Okay? Because most of them will die while they're inside the ovaries. All right, so all of these primary oocytes that is in development, right, that are all stuck in prophase 1, that are all found inside the ovaries, they are all surrounded by a layer of cell. That layer of cell is a flattened layer of cell, and we call those the follicular cells. So therefore, remember, we talk about follicular cells in the thyroid gland. So here we have follicular cells in the ovaries as well. But those follicular cells are flat, so they're squamous looking cells, and they surround this primary oocyte that is stuck in prophase 1. Together, that whole structure is referred to as a primordial follicles. So essentially, the female individual, very early on in development as the embryonic stage, they have roughly about 7 million of those primordial follicles. Okay? By the time they are born, that amount decreases down to about 2 million primordial follicles. By the time she reaches the age of puberty, the amount of primordial follicles decreases down to about 400,000, and roughly throughout her whole lifetime, she will ovulate roughly about 400 of those 400,000 primordial follicles. Okay? All right. And the rest of it we're going to talk about in a second. Okay, that's just basically what we call oogenesis, or development of the eggs. Now, once the female individual, so we're going to fast forward, right, until the female individual reaches what we call the age of puberty. Once she reaches the age of puberty, she goes through 2 cyclic changes that involves 2 different organ systems. So one organ system, but 2 different structures within that organ system. One of these cyclic changes that occurs once she reaches the age of puberty occurs within the ovaries. So we call that the ovarian cycle. The other cyclic changes that occurs within what we call the endometrium of the uterus. So we call that the endometrial cycle, or the uterine cycle. So both the ovarian cycle and the endometrial cycle basically matches up very well. And it takes roughly about 28 days or so to complete each cycle. Okay? So therefore, both of those, the ovarian cycle, all the cyclic changes that happens inside the ovaries, match with all the cyclic changes that happens inside the endometrium of the uterus, basically combine together to form what we call the menstrual cycle. Okay? So for the menstrual cycle, these are the phases. So you have the ovarian cycle. And within the ovarian cycle, so we'll say this is 1. Within the ovarian cycle, you will have the first phase called the follicular phase. Okay. The second phase is called ovulation. And the third phase of the ovarian cycle is referred to as the luteal phase. Okay. The follicular phase occurs anywhere between day 1 to about day 13. Ovulation occurs on day 14, 15, one of those. And then luteal phase occurs anywhere between day 15 to day 28. Okay. Now, while this is happening, there are also cyclic changes that occurs within the endometrium. So we'll call that the endometrial cycle. So in the endometrial cycle, there's also 3 phases that occurs in coordination with those phases in the ovaries. The first one is a very short phase, and it takes roughly about 4 days or so, and this is called the menstrual phase. We'll call it something else just to kind of differentiate that. Because remember, this is called the menstrual phase. The whole thing is called the menstrual cycle. Okay, so don't confuse those 2. So we'll call this menstruation. Okay, and menstruation takes about 4 days, so day 1 to day 4. The second phase is called the proliferative phase. takes from day 5 to day 14. And the third phase within the endometrium is called the secretory phase. And this takes place on day 15 to day 28. Okay, so all these particular phases match up with each other very nicely. Two different phases, two different cyclic changes that occurs. One's occurring inside the ovary, the other one's occurring inside the uterus. Okay, all right. Let's see how it works. All right, so now imagine you have your primordial follicles. Okay, the primordial follicles will have the oocytes within it. So here's the oocyte housed within that primordial follicle. And the oocyte's going to be surrounded by a flattened layer of follicular cells. Okay, so flat layer. So it looks like squamous cells surrounding this thing. Okay, so the whole thing we call the primordial follicle. Because the follicle itself houses that oocyte. And this oocyte is your primary oocyte. And remember, the primary oocyte is stuck in prophase 1, right? So arrested at prophase 1. Okay. So in order for this particular follicle to start to develop, there has to be a series of hormonal regulation, right? Because reproduction in males and females alike is regulated by hormones. So therefore, to regulate the production or the development of these particular follicles, hormones has to be secreted. So there's a hormone secreted by the hypothalamus. Okay, and the hormone is gonadotropin releasing hormone. Okay, so your GnRH is secreted. And what does the GnRH stimulate? What does gonadotropin releasing hormone stimulate? Anterior pituitary. Okay. Anterior pituitary will secrete follicle stimulating hormone. Which is your FSH. Okay. It will also secrete some amount of what we call luteinizing hormone. Which is your LH. But in the beginning, when you try and stimulate the follicles, it's the follicle stimulating hormone that actually has any kind of stimulation to the follicle. Luteinizing hormone doesn't have any stimulation to these follicles at all. Okay. All right. Now, to stimulate the hypothalamus to release gonadotropin releasing hormone, remember, very early on in puberty, you need another hormone. What's that other hormone that stimulates the release of gonadotropin releasing hormone from the hypothalamus? What do you call that one? Remember I told you guys to ensure adequate, let's say, time frame for the onset of puberty, because you don't want to delay that puberty. The female individual has to have a certain amount of adipose tissue, right? The adolescent girl. If skinnier, you have skinnier girl, more athletic girls and stuff like that, they most likely will have some amount of delayed puberty. So they may not initiate puberty until they're maybe about 12, 13 years of age, whatever it is. So what is secreted by the adipose tissue that's so important for the onset of puberty? Leptin. We have adipose tissue secreting leptin. And leptin will stimulate the hypothalamus. follicle-stimulating hormone is going to move all the way into the blood or transport into the blood and stimulate the primordial follicle. Once the primordial follicle is stimulated, it's going to start to, okay, I don't want to, it's all right, I don't need to advance the slide yet. So once the primordial follicle gets stimulated by FSH, it will start to develop. Basically, these cells start to develop. The oocyte stays the same, okay? So when we're talking about this, think about this in two separate things. The follicular cells and the oocytes, right? Together they make that follicle. So therefore, FSH is known as follicle-stimulating hormone, which by its name will stimulate the development of the follicles, or stimulate that follicle to basically mature to a certain degree. So then this follicle will start to mature. Basically, here's the oocyte still stuck in prophase 1. In response to FSH, these cells here, they become cuboidal in shape. So they're no longer squamous or flat, but they become cuboidal. Okay. And then eventually they develop further so that cuboidal cells will become somewhat stratified cuboidal. So now at least there's 2 layers of cuboidal cells. Okay, makes sense? All right. In this form, once these cells basically become a little more cuboidal and then become more stratified, we call both of these the primary oocytes, or the primary follicle, sorry. Okay, so primordial follicles surrounded by a flattened layer of follicular cells, primary follicle surrounded first of all by a single layer of cuboidal follicular cells, and eventually a stratified layer of cuboidal. But once that cuboidal cells become stratified, we no longer call them the follicular cells. We now refer to this layer of cell, because that is the layer of cell that's going to be rapidly dividing and become thicker and thicker. We call this layer of cells the granulosa cells. Okay. So the primary follicles later on is going to be surrounded by the granulosa cells, surrounding what we call the primary oocyte. Okay. Now, this granulosa cell is going to start to secrete an extracellular matrix right at the border, right at the membrane of those particular oocytes. So therefore, this extracellular matrix is sort of like a hardened material that protects that oocyte. Okay. So the extracellular matrix here we call that zona pellucida. Okay. So zona pellucida is that green line that lines that oocyte. That oocyte is still a primary oocyte, still stuck in prophase 1. Okay, so the oocyte in here, that is still your primary oocyte. Okay, so far so good. All right. Now, as FSH continues to stimulate this, because FSH is still the main one, so I'm going to draw FSH here, just so you guys don't lose sight of the fact that FSH is the main hormone that continues to stimulate the development of these guys. Okay. As FSH continues to develop these things, it will eventually develop into a much larger structure. And this larger structure still surrounds your primary oocyte, still has the zona pellucida surrounding it like that. Okay. Still have these granulosa cells. So granulosa cells surrounding it. This, but it's essentially once this starts to develop even more, some of these granulosa cells, they become thicker and thicker, right? And then between two layers of granulosa cell, they start to secrete these extracellular substances filled with like hormones and nutrients and fluid and stuff like that, that causes the granulosa layer of cells to separate. So therefore, the granulosa cells eventually have a separation between them. So we're just gonna color that in like that. That indicates the granulosa cells that's still surrounding the zona pellucida and surrounding the primary oocyte. Here you have other granulosa cells that has separated from the inner layer of granulosa cells. And now it becomes something like this. So out here, these cells here are still called the granulosa cells. Okay. That green line is still the zona pellucida, that egg is still the primary oocyte. But because you have now a separation of these granulosa cells, you have a layer of cells that is surrounding that zona pellucida. So we call that layer of cells the corona radiata. Okay. And as these two layers of cells separate, there's a fluid that starts to accumulate in that particular area. So there's a fluid in there. Okay. And that fluid is referred to as the antrum. Okay. So therefore, once you start seeing the primary oocyte still surrounded by the zona pellucida, surrounded now by what we call corona radiata, there's a little bit of an antrum that starts to form, and then the surrounding cells outside of that is still referred to as the corona radiata. So therefore, this follicle is referred to as a secondary follicle. Okay. Now FSH still continues to basically stimulate this thing, right? So you still have FSH stimulating it. So therefore, eventually it will continue to develop even more. As it continues to develop, eventually it's going to become a very large structure. So actually, let me drop this a little bit here. Okay, so here's your oocyte surrounded by the zona pellucida. Surrounded by your corona radiata. And then over here, there's a little bit of stalk. And now you have this really large structure. Okay. Very thick layer of granulosa cells, with also a large amount of antrum. Okay. So it's still the same thing. So basically, if you think about all the contents that make up this structure, right? You still have the oocyte protected by your zona pellucida, surrounded by the corona radiata, but now you have a very thick layer of granulosa cells and a huge amount of antrum. Okay? So when you see this appearing within the ovaries itself, this is what we call a mature or Graafian follicle. Okay? All right. Now, one other thing to note as we kind of go back a little bit, once these granulosa cells are formed, once these follicular cells become granulosa cell, as FSH stimulates it, the granulosa cell will start to secrete a hormone we call estrogen. And of course, you can imagine that at the very beginning, the granulosa cell will secrete only a very small amount of estrogen. because it's not a very thick layer of cell. Okay. As these granulosa cells grow bigger and bigger, because FSH is still stimulating it, it will secrete more estrogen. And then as it gets into its what we call mature stage, or the Graafian follicle stage, it will secrete a very high amount of estrogen. Okay. All right. So this high amount of estrogen toward this particular stage of development of this mature Graafian follicle, as the estrogen amount is very high, now has a positive feedback onto the hypothalamus and the anterior pituitary. Okay. But before we talk about that, here's some picture I want to show you guys. So here's a bunch of primordial follicles here, smaller, and then you have, this is a secondary follicle. You can see that here's the oocyte sitting in there. That line right there, that's the zona pellucida. And then you have a faint corona radiata, and a little bit of an antrum basically starting to form. Okay. Eventually, this is what we call a Graafian follicle, a mature follicle. You can see here's the oocyte. In here, you can see a very thick zona pellucida. Right. You can see all these cells surrounding it. That's called the corona radiata. And then you have a very thick layer of granulosa cells out here, right? And a very big lake here called the antrum, right? The amount of fluid that accumulates within this area is now very, very large. Okay. All right. So, toward the end of this development of the mature Graafian follicle, because it secretes now a huge amount of estrogen, estrogen now has a positive feedback onto the hypothalamus and your anterior pituitary. Okay. So as the hypothalamus receives stimulation from estrogen, it will secrete gonadotropin-releasing hormone, right? Because that's what it does. And that gonadotropin-releasing hormone is going to stimulate the anterior pituitary. So therefore, the effect of both estrogen and gonadotropin-releasing hormone acting on the anterior pituitary is going to stimulate the anterior pituitary to secrete a very, very high amount of luteinizing hormone. Okay. Very high amount of luteinizing hormone. And because it can't help it, it also secretes FSH, but not as much. FSH is being secreted at this point. So comparing the two, the amount of luteinizing hormone secreted during this positive feedback activities within this, around this mid-cycle time of the ovarian cycle, it's going to stimulate a very high amount of LH secretion and slightly, high amount of FSH, but not as high in comparison. Okay. So therefore, this huge amount of LH secreted during this particular feedback is referred to as the LH surge. So it's a huge surge of luteinizing hormone. Now what luteinizing hormone does is that, let me go to this page first. The first thing it does is that it will now have basically act back onto this mature Graafian follicle. But what it does, actually it starts with this primary oocyte. So the LH surge, this high amount of LH, is going to stimulate that primary oocyte to basically complete meiosis 1. Remember, it was stuck in prophase 1 throughout all this time, right? So now that high amount of LH is going to stimulate that primary oocyte to now go through meiosis 1, finish it. Go through metaphase 1, anaphase 1, telophase 1, and then cytokinesis. So now 2 secondary oocyte is formed. Okay, after that first round of meiosis, one of these secondary oocyte dies immediately, randomly. They'll pick one and that one just dies. So therefore, the remaining secondary oocytes starts to go through meiosis two. But it's then, again, stopped prematurely in metaphase two. And it stays in metaphase two until it becomes fertilized by a sperm cell. Okay? So the LA search is important because the LA search first we'll say stimulates primary oocyte to complete meiosis 1 to form 2 secondary oocytes. And then from there, one secondary, well, we'll just say it all out. One of the secondary oocytes die. The remaining goes through meiosis 2. Rested in metaphase 2. Okay, so that's what happens to these oocytes in here. As the LA search basically now goes back to stimulate all of that pathway. The second thing that also happens several hours after the maturation of that secondary oocyte. So basically, once the LA stimulates the primary oocyte to become a secondary oocyte, several hours after that, it would then stimulate these particular cells of the Graafian follicles, and of course, there's other cells that surround it, called the theca cells, but we're not gonna talk about it. So essentially, it stimulates all of those cells to basically goes through a little bit of a spasm effect, right? And this spasm effect is aided by some of the smooth muscles surrounding this particular structure, and therefore, it causes that Graafian follicle to rupture. And as it ruptures, it ejects out the secondary oocyte surrounded by the zona pellucida, surrounded by the corona radiata. So essentially, the LH that has fed back, or that basically is now released by the anterior pituitary, is gonna cause this mature Graafian follicle to do this. Let's see if I can draw it rupturing. Sorry, kind of looks like a little pineapple. So you have all of this antrum, and within the antrum, there's gonna be some degree of blood vessels, so therefore there's a lot of bleeding that occurs within this area. And through this contraction, all this spasm is going to eject out this structure. Okay. So it's gonna eject out this oocyte. Surrounded by the zona pellucida. And surrounded by that corona radiata. Okay. So that ejection we call ovulation. Okay. So. Make sense? So the LH, the luteinizing hormone, is important because the luteinizing hormone is stimulating, first of all, the complete maturation or completion of meiosis 1 of that primary oocyte. And then the surviving secondary oocyte goes through metaphase goes through meiosis 2 and then it's stuck in metaphase 2. But secondly, that huge amount of LH is going to stimulate that mature or graphene follicle to go through some kind of a spasm and therefore eject out that secondary oocyte. So we call that ovulation. Okay? So this here is referred to as ovulation. And again, it's all stimulated by LH. Good. Any questions so far? Okay. Now, I'm gonna erase this one, okay? You guys should already have this. Okay, so now, once the oocyte has been ejected, it's no longer part of the ovaries, but what remains inside the ovaries still continues through its overall process. So therefore, the empty graphene follicle is going to combine with the some of the surrounding cells and tissues under LH stimulation to essentially form what we call this endocrine structure that kind of looks sort of like that. Okay, so the empty graphene follicle and the surrounding cells and stuff like that under LH stimulation basically form this structure. This structure is called the corpus luteum. Okay, and this is under LH stimulation. And constantly under LH stimulation, the corpus luteum will secrete estrogen and, more importantly, progesterone. Okay. So the corpus luteum will now secrete two hormones, both estrogen and progesterone. Good. Any questions about this? All right, so therefore, all of this development of your follicles is under FSH stimulation, follicle stimulating hormone stimulation, up until the formation of the mature graphene follicle, right? So all of this occurs within the first 13 days or so of the ovarian cycle. Okay, so up until the development of this graphene follicle, and of course, because more estrogen is being secreted, there's a positive feedback that's happening. So all of that is what we call the follicular phase of the ovarian cycle. Okay. Now, during this positive feedback, so this is occurring somewhere within day 15 or so, this positive feedback is going to increase the amount of LH that is being secreted by the anterior pituitary. So you have this LH surge, right, very, very early on in that particular time, in that day 14. Right? So that LH now stimulates that primary oocyte to complete meiosis 1 and then becomes two secondary oocytes, one of which dies, the other one goes through meiosis 2 and they are arrested in metaphase 2. Okay? Several hours later, that LH now stimulates the rest of that graphene follicle to go through spasm and eject out, or ruptures and eject out that secondary oocyte. Therefore, ovulation occurs. So this is all happening within day 14 or so. And we call this the ovulation phase of the ovarian cycle. Afterwards, LH continues to stimulate the empty graphene follicle and some of the surrounding tissue to basically fuse together to form this structure called the corpus luteum, which is still inside the ovaries itself. Now, for the next several days, from day 15 to about day 28, the corpus luteum will continue to secrete estrogen and progesterone, okay, under the stimulation of luteinizing hormone. Okay, so follicle stimulating hormone stimulates the development of the follicles within the follicular phase of the ovarian cycle. luteinizing hormones will be the main hormone that stimulates ovulation. Then after that, luteinizing hormone will continually stimulate the function of the corpus luteum within the luteal phase of the ovarian cycle. Does that make sense? Right? So everything kind of goes together in terms of terminologies if you guys ever forget where they lie. Okay? So the luteal phase is maintained by the corpus luteum, which is maintained by luteinizing hormone. It's all part of that. And of course, just remember the amount of estrogen and progesterone being secreted by that particular structure during that luteal phase. Okay? In the beginning, it's all the granulosa cells that secretes these particular estrogen that has that positive feedback. Now, with this estrogen and progesterone, what it does is that now it has a negative feedback onto the hypothalamus and your anterior pituitary. Okay, so progesterone mainly is going to have that negative feedback. So you can think about both of them acting together. But because progesterone is the main difference here in this third phase, that's why I only talk about progesterone. So progesterone has this negative feedback to the hypothalamus, which prevents it from secreting GnRH, or gonadotropin-releasing hormone. Okay? Progesterone also has a negative feedback onto your anterior pituitary. With that negative feedback here, it actually stops the secretion of FSH. And it gradually decreases the secretion of LH. So LH is still being secreted, but gradually starts to decrease. Now, the reason why the corpus luteum, as it secretes that progesterone and estrogen, the reason why that progesterone has that negative feedback onto the hypothalamus is to prevent the hypothalamus from secreting any more gonadotropin-releasing hormone. And of course, it also has a negative feedback onto the anterior pituitary. Now, of course, without gonadotropin-releasing hormone stimulating the anterior pituitary, it's not going to release any further hormone. But because progesterone is also acting on it, therefore, the anterior pituitary will stop secreting follicle-stimulating hormone. Because the reason for this is this. You already have an oocyte being ovulated and now swimming inside the fallopian tube. The body is thinking that oocyte will eventually become fertilized by a sperm cell. And if it does, it will develop into an embryo, right? And the human body is only made to support one life form at a time. So twins, triplets, and all of that stuff are all what we call anomalies. They're abnormalities in terms of pregnancy, okay? Because the human body is geared only to carry and support one individual life form for whatever that gestational period is. So therefore, the reproductive system of this female individual knows that there's already one of these oocytes out. And potentially that secondary oocyte will become fertilized. And if it does, it will become an embryo. So therefore, we're not going to maturate or develop any other follicles during this time. Due to that thinking, that progesterone now has a negative feedback onto the anterior pituitary to prevent any further FSH secretion. Because if you have FSH being secreted, it's going to stimulate the development of another follicle, which you don't want during this time. Does that make sense? Right? Because potentially, what if that secondary oocyte and that follicle there gets penetrated by a sperm cell and it becomes fertilized? Then now you have to support a life and also start to develop all of these. It's too much work, right? It's too much stuff going on, so the body's stopping all of that stuff. Now, the other thing that you also have to keep in mind is because LH is gradually being decreased in terms of the anterior pituitary secreting the luteinizing hormone. Corpus luteum depends on luteinizing hormone to stay alive. So by having a negative feedback onto the anterior pituitary, the corpus luteum is slowly killing itself. Does that make sense? Because it releases progesterone, which now prevents the anterior pituitary from releasing any further luteinizing hormone, or at least the amount of luteinizing hormone starts to decrease gradually from day 15 to about day 28. And furthermore, the response of the corpus luteum toward luteinizing hormone in the later part of that luteal phase is actually becoming less and less sensitive. Okay? For some reason, probably because this corpus luteum starts to take away some of those receptors and therefore is no longer as responsive to luteinizing hormone. It is actively trying to kill itself. Okay? That's a great thing about this reproductive structure. It is self-regulated to the utmost efficiency. So during day 15 to day 28, which is what we call the luteal phase, right? This corpus luteum, as it secretes estrogen and progesterone, have this negative feedback onto the hypothalamus and anterior pituitary, which basically stops the secretion of FSH from the anterior pituitary to prevent any further development of another follicle during this time. Secondly, the amount of luteinizing hormone gradually decreases, which means the corpus luteum will slowly start to die. Okay? So throughout those last few days of the luteal phase, the corpus luteum starts to regress. And as it regresses, which means it's now slowly dying because it's no longer as responsive to luteinizing hormone, and furthermore, there's not enough luteinizing hormone for it to become responsive, the amount of estrogen and progesterone starts to slowly decrease. If there is no fertilization at the end of day 28, or if there's no fertilization anywhere throughout that time frame, eventually, once you reach the end of day 28, the corpus luteum will die. Once the corpus luteum dies, the amount of estrogen and progesterone is significantly reduced. Obviously, there's nothing else secreting these guys. So because of that, the negative feedback is lifted and the cycle starts all over again. Does that make sense? So the corpus luteum will die if there's no fertilization, and because the corpus luteum dies, the amount of estrogen and progesterone is no longer secreted. Without estrogen and progesterone being adequate, there's no longer any negative feedback. If there's no negative feedback, the hypothalamus will now secrete the gonadotropin-releasing hormone, which then stimulates the anterior pituitary to secrete follicle-stimulating hormone. And the follicle-stimulating hormone will stimulate the development of another series of primordial follicles. And it starts all over again. Okay? So that's what you guys have to know, because we're not going to talk about pregnancy in this class, right? Pregnancy is an entirely different spectrum altogether of those hormonal regulation, stuff like that. Okay? Good? So all of this leading up to the mature grafting follicle is what we call the follicular phase of the ovarian cycle. From this point of positive feedback into the rupture and ejection of that secondary oocyte, we call that ovulation. After that, the empty grafting follicle under LH stimulation becomes the corpus luteum for the remaining time to secrete estrogen and progesterone. We call that the luteal phase. So follicular phase, ovulation, luteal phase. Okay, the three phases of your ovarian cycle. Okay. That slide just talking about ovulation. Here's a bunch of positive feedback that enhances the secretion of LH, which then induces that rupturing and ejection. It's a nice moment of ovulation that's captured. Here's the capsule of the ovaries on this side. You can see that the actual capsule of the ovaries will rupture, and the egg, the oocyte surrounded by all of these cells, is actually ejected out. And when we look at it, these cells look like they grow. They not grow, but glow, sorry. They glow surrounding that particular secondary oocyte. So therefore, it's known as the glowing crown, hence corona radiata. Okay. And here's the fimbriae of your fallopian tube that is going to capture this oocyte to bring it in. Okay. Oftentimes, it misses. And if this particular oocyte is not brought into the fallopian tube, it may still be floating around within the pelvic cavity somewhere. And if, very rarely that occurs, but a sperm may penetrate through all of this and fertilize that oocyte. And if that's the case, that oocyte, once it becomes fertilized, will find a blood source. Because you need a huge amount of blood supply in order to, deliver adequate amount of nutrients to that growing embryo. So therefore, if that fertilized egg is not inside the uterus by the time it reaches there, it will find something to implant itself onto. If that's the case, we call that an ectopic pregnancy. Okay? So any kind of fertilization and implantation outside of the uterus is referred to as an ectopic pregnancy. Okay? Now, even within the uterus itself, there's a perfect place for it to land and implant itself. Because if it implants itself too far down and it becomes close to the cervix, then there's a chance of it basically not stabilized enough within that uterus, and it may break out. And if it does break out, there's massive amount of bleeding. And if that happens before week like 20 or so of development, we call that a spontaneous abortion. Okay, because the baby's got to be lost, the embryo's got to be lost in that time. All right. That's just an explanation of the luteal phase. So the empty Graafian follicle here, under luteinizing hormone stimulation, will start to develop into the corpus luteum, and still continuing under LH stimulation, continue to secrete estrogen and progesterone, which now has a negative feedback onto the hypothalamus and the anterior pituitary. Okay. Keep in mind there's also inhibin that's secreted. So remember, very early on in this particular progression here, there's some amount of inhibin secreted by these granulosa cells, and that's the reason why the amount of FSH that is secreted during this positive feedback compared to the amount of LH is not as high, because inhibin has inhibited the anterior pituitary to decrease the secretion of FSH to a certain degree. Okay. Because remember, inhibin is only acting on the anterior pituitary to inhibit any further release of FSH. It has no activities, no bearing, or no kind of regulation to the secretion of LH itself. Okay. Questions? So again, just all the progression of these particular follicles within the ovaries. Here's a moment of ovulation, and here's the transformation of the empty Graafian follicle into this structure called the corpus luteum. Once the corpus luteum dies, it becomes this scar-like tissue called the corpus albicans. Okay? So you can see, and you can check, and you can chart actually how often or how many times that female individual ovulated throughout her lifetime by checking the amount of corpus albicans that she has inside the ovaries. Here's the hormonal chart. So here's FSH and LH. You can see that during the follicular phase, FSH is a little bit higher, right? FSH is continuing to stimulate the maturation of the follicle until you get to this particular point of ovulation. You can see there's a huge spike in luteinizing hormone. Okay. You can still see a little bit of a spike in FSH, but there's significantly lower due to the fact that there's also inhibin to limit the amount of FSH stimulation or FSH released. And then luteinizing hormone continues to stimulate the empty Graafian follicle to form your corpus luteum within this luteal phase. But eventually the amount decreases and this corpus luteum become more and more desensitized to the effects of that LH. Right? And then as it dies, it becomes the corpus albicans. Okay. All right, good. Questions? Okay, now in the uterus, or in the endometrium of the uterus, which is the innermost lining of the uterus, you also have these changes that occurs. Okay? And those changes are occurring in coordination with the changes that occurs within the ovaries. So I'm just going to draw a very small area right here for you guys. So imagine in the uterus itself, there's the inner lining of the uterus called the endometrium. But the endometrium actually has two layers itself. The bottom layer of the endometrium, which is always constant, we call this the basal layer of the endometrium. Okay. Now, there's a layer sitting on top of this basal layer of the endometrium that will grow significantly. But that growth depends on a hormone, and that hormone is estrogen. So imagine this estrogen here that is being secreted by these granulosa cells a little bit here, a little bit more, and a lot more during the development of those follicles. So let's just start over here. So the estrogen actually acts onto the basal layer of the endometrium. So therefore, the estrogen secreted by the granulosa cells in the ovaries, its target will be the basal layer of the endometrium. And as it acts on the basal layer of the endometrium, it stimulates this layer to grow. And as it grows, it proliferates, so it becomes multiple layers of cells, right? So as it proliferates, we call this the proliferative phase. So here, proliferation of. Now, the top layer of this endometrium that proliferates is referred to as the functional layer of the endometrium. So we have now estrogen stimulating the proliferation of the functional layer. Of the endometrium. Okay. So it grows extensively and massively. Okay. And as it grows, blood vessels coming from the basal layer of the endometrium also grows into these layers. And these blood vessels are referred to as the spiral arteries because they are spiral in formation. Okay. So the spiral artery starts to develop or basically develop into this functional layer of the endometrium as it grows massively due to the effect of estrogen, right? You can imagine all these estrogens doing the same thing to this functional layer. Now eventually, once ovulation has occurred and the empty grafting follicle becomes the corpus luteum, and the corpus luteum secretes progesterone and estrogen, one of the functions of progesterone, besides having this negative feedback onto the hypothalamus and the anterior pituitary, is to stimulate this functional layer. So now you have progesterone stimulating this functional layer as well. Okay. So as progesterone stimulates this functional layer, it actually limits the amount of growth of this functional layer, but it causes the functional layer to form these deep crevices. Now, what these deep crevices do is that the amount of blood vessels, the amount of spiral arteries from the basal layer is a lot thicker now. So there's a high degree of vascularization. So a lot of blood vessel feeds into this particular layer. Can you imagine? That's a huge amount of blood flow, right? Now that is going to cause these crevices allow for these blood vessels to secrete nutrients into these crevices. And these nutrients are very important because if this secondary oocyte happens to be fertilized, if this egg happens to be fertilized, it will implant itself onto this functional layer of the endometrium. And immediately as it implants itself on here, it's gonna start to take up all of these nutrients so that it can massively grow. Does that make sense? Okay. So therefore, you're creating, in terms of this particular individual, the reproductive system is thinking this way. Every single month, I'm gonna get pregnant. So therefore, every single month, I need to prepare for a possible implantation of that fertilized egg. So she has to create in her uterine lining, in her uterus itself, she has to create this very nice and comfortable bed for this particular, that secondary oocyte, just in case it gets fertilized. It's gonna implant itself. It's gonna stay there for the next 9 months. So you better have a huge amount of nutrients and blood supply to allow for that secondary, or to allow for that fertilized egg to grow into an individual, into a complete organism. Okay. So this phase right here, where you have proliferation of the functional layer of the endometrium and basically the vascularization of the spiral arteries piercing into this functional layer, that is all stimulated by estrogen itself. We call this the proliferative phase. of the endometrial cycle, which is happening between day 15 to about day 5 to about day 15. Okay, so we call this phase right here the proliferative phase. And once progesterone is secreted by your corpus luteum, which means that this is now coinciding with what we call the luteal phase of your ovarian cycle. That progesterone, actually let me lift this a little bit. That progesterone is going to stimulate that functional layer to secrete a huge amount of substances into these crevices. Nutrients into the crevices here. So therefore, we call this the secretory phase of your endometrial cycle. Okay. So proliferative phase is occurring between day 5 to day 15. Secretory phase or day 14. Secretory phase is from day 15 to day 28. 5 to 14, and this one, day 15 to day 28. Okay. All right. Now, what happens if you don't have fertilization occurring? So you have ovulation occurring, but there's no sperm there to basically fertilize that egg. You guys can understand that eventually, because of this negative feedback, this corpus luteum will regress and dies, right? Because of the fact that there's less luteinizing hormone and there's also a decrease in sensitivity to that luteinizing hormone. So eventually that corpus luteum dies. Once the corpus luteum dies, the amount of progesterone decreases as well, significantly. Once that progesterone decreases, I'm just gonna draw some of these arteries in here. Once you no longer have progesterone, it causes these spiral arteries to become constricted. So there's a vasoconstriction of spiral arteries due to lack of progesterone. All right, so toward the end of the secretory phase, if there is no fertilization of that secondary oocyte, the corpus luteum regresses and dies. And as the corpus luteum regresses and dies, the amount of progesterone will decrease. Okay? If you don't have adequate amount of progesterone, there's a vasoconstriction that occurs at the spiral arteries. Now, if you vasoconstrict any arterial vessel, what's going to happen to the blood flow?
Cut off.
It's going to cut off. So what's going to happen to the tissue that receives that blood flow?
Will die.
It's going to die. And what we call that kind of cell death. The cells die by two ways. One, you stimulate it to go through cell suicide. We call that apoptosis. Two, it dies because you cut off the blood supply. And we call that necrosis. So therefore, this tissue here, because you cut off the blood flow, is going to start to die via necrosis. So as it dies, continues to die, now this leads all the way back into the first phase of the endometrial cycle. So imagine now you have this particular layer that is dying very rapidly. Okay. Here. So, necrosis of the functional layer the endometrium. And when you have necrosis of that functional layer of the endometrium, as it starts to die slowly, it's gonna start to break off blood vessels. So you're gonna have active bleeding occurring during this particular time. Okay, so you're gonna have active bleeding occurring. And what's more is that as this particular functional layer of the endometrium starts to die, it will separate itself from the basal plate. As it separates itself from that functional layer, it's going to basically break off some of the arterial vessels. So during this first few days, first 4 days or so of this endometrial cycle, you now have active shedding of necrotic tissue and active bleeding from within the uterus itself. So we call this particular phase menstruation. And menstruation, for the most part, takes about 4 days to complete. So this occurs from day 1 to day 4. After that, because within the follicles of the ovaries, they start to secrete estrogen, so now you start to rebuild the functional layer. So then you get into what we call the proliferative phase. So all of this happening up there, that's basically part of what we call the follicular phase. Okay, so follicular phase of the ovarian cycle takes place anywhere between day 1 to about day 13. This ejection here, ovulation, is on day 14. And the rest of this, with the maintenance of the corpus luteum, that is your luteal phase, which is day 15 to day 28, in coordination with the secretory phase of the endometrial cycle. Okay? Questions? Okay. So ask yourself, what hormones help to maintain these particular phases, either within the ovaries or within the endometrium, okay, of the uterus itself? And where do those hormones come from? And how do you regulate those hormones during these particular cyclic times, right? In order for you to have ovulation, in order for you to have menstruation and things like that. So obviously, if that egg becomes fertilized, you maintain this functional layer of the endometrium. Right? There's no menstruation happening. Due to the fact that that fertilized egg will develop and will now start to secrete progesterone. Or sorry, will start to secrete other hormone and progesterone too, but also helps to maintain that corpus luteum for a long period of time. Because of the fact that there's still going to be some amount of this luteinizing hormone being secreted. And there's other hormones secreted by that secondary oocyte or the fertilized egg that will help maintain viability of that corpus luteum as well. For a certain number of time, and then once that embryo starts to form and form a placenta, that placenta will now secrete hormone to maintain it for the rest of the pregnancy. Because that corpus luteum is no longer useful toward the end of that pregnancy. But like I said, we don't care about pregnancy at this point, right? We only care about the normal, everyday occurrence without the pregnancy being involved. So sorry, prolific. Yep.
Sorry, I have a question. Going back to the endometrium, you said what causes the folds? Where
The crevices?
Yeah.
Well, the crevices has already been formed, right? But it becomes deeper. So that's due to mainly the progesterone effect. As progesterone being secreted out by the corpus luteum, it will stimulate the formation of those deep crevices even more. But the more important thing is that it stimulates the secretion of the nutrients from the spiral arteries.
Okay. And that's in the proliferative phase?
No, the progesterone is maintaining what we call the secretory phase. Estrogen is maintaining the proliferative phase because estrogen stimulates the proliferation of the functional layer Whereas progesterone stimulates the secretion coming, from those spiral arteries and stuff.
If menstruation is shedding of like dead tissue,
Proliferation is growth.
no, menstruation.
Oh, menstruation.
Yeah, shedding like of
Yeah.
necrotic tissue, right?
Mhm.
Why is there pain associated with that?
Because in order for you to effectively shed and eject out the necrotic tissue, there's a lot of muscular contraction. And that's why during that time, there's a lot of cramp and stuff like that can manifest. Right? Of course, you're shearing those tissue, right? You're breaking blood vessels too. So there's a lot of things involved because there's some degree of inflammation that's going on in there to allow for that shedding of that tissue to occur. So that's why there could be pain. And the pain mainly is due to that muscle contraction around the uterus itself to help to get rid of that tissue. Cool. All right. And that's just the rest of that. So again, with the hormones itself, in the second phase, we'll talk about menstruation after. In the second phase, called the proliferative phase, right? Estrogen secreted by your granulosa cells in the ovaries will stimulate the proliferation of the functional layer of the endometrium. Okay? And then once ovulation has occurred inside the ovaries and the empty Graafian follicles become the corpus luteum, and it starts to secrete high levels of estrogen and progesterone, that progesterone is going to stimulate the increase of secretions into these deep crevices that is formed, and now it's becoming much, much deeper. Right? Before, there's some degree of these crevices here, but it's not as, I guess, convoluted or complex as these things. Okay? There's a high amount of nutrients stored within these crevices, just in case that oocyte becomes fertilized and implants onto that area. Okay? And if there is no fertilization, the corpus luteum eventually dies. Estrogen and progesterone is no longer secreted. There's a vasoconstrictive effect of these spiral arteries itself that causes these tissue, the functional layer of the endometrium, to go through necrosis, to die via necrosis. As it dies via necrosis, it will also separate itself from the basal layer, and therefore it gets shedded out during menstruation. Okay? While that is going on, while this menstruation is going on, remember, there's no longer any negative feedback here. So therefore, hypothalamus secretes gonadotropin-releasing hormone, anterior pituitary secretes follicle-stimulating hormone, and for the first 4 days or so, this is now happening inside the ovaries, right? Until eventually it forms that granulosa cell enough so that it can secrete adequate amount of estrogen. That estrogen will start to, or stimulate the rebuilding of this functional layer.
So in normal situations, by the end of the menstruation cycle, they should have the menstrual cycle, the primary follicles is already formed.
It's already there, right? All the primary follicles that has already been sitting there. It's just sitting there dormant until they get stimulated.
They stimulated.
Yeah, that's it. Because they're all surrounded by those follicles, right? So the cells, the follicular cells, has to be stimulated. And to trigger the stimulation, that's FSH.
Mm-hmm.
So FSH triggers the development of these guys and they start to develop. The primary oocyte is always there.
Okay.
And eventually it gets developed into a secondary oocyte by LH.
Got it.
Yeah. And every single time the female individual goes through this process, it's not just one primordial follicle that gets stimulated. It's hundreds of these guys that get stimulated. But only one becomes the mature follicle. And that one will be selected for. The rest of it dies within the ovaries. And they don't form any scar tissue. They just die, get resorbed into that tissue. But that remaining one will eject out that egg and becomes the corpus luteum, which then becomes a scar structure called the corpus albicans. Right? So throughout the lifetime, the female individual will go through all of this process. Right? It's a little more complicated than the male reproductive system. Right?
Just a little bit.
Just a little bit. It's a lot more moving parts and coordination and stuff like that. Because, I mean, you have to, first of all, provide an egg for the sperm to fertilize. Second of all, you now have to be that bed and breakfast for the next 9 months, right? So that bed better be pretty comfortable. Okay, imagine you lying in a bed for like 9 months straight. You better have like nutrients brought to you, or food and drinks and stuff like that brought to you and stuff like that. So everything has to be prepared ahead of time. And that's what the body is thinking. That's what the female individual is thinking. Okay. All right. Okay, so let's say at some point in the female's life, she may not want any more kids. Okay, so what's one of the contraception that she can use? Like some form, because every single time you come across or you deliver a baby from your patient, you always have to ask them afterwards, do you have any plans for contraception? And the individual may tell you, no, I want more kids, so we're not planning for any contraception right now. And that's fine, nothing wrong with that. But if she does, then of course you give her some options, right? Obviously, abstaining from sex is one, which doesn't work, especially if they're active partners. Condoms, sometimes it works, sometimes it doesn't, right? Depends on the user themselves, okay? But you can also offer things like an injection, hormonal injections to basically regulate the amount of, the overall menstrual cycle. You can also give, the most common one is oral contraceptive pills. Those pills contain estrogen and progesterone. So essentially, it's tricking the female individual, the female body into thinking, I'm pregnant. And that's why she doesn't ovulate. So when the female individual is on the oral contraceptive pills, she does not ovulate at all. But she still builds this thick layer of tissue. Why? Because she has estrogen and progesterone from the pill itself. So therefore, the pill is stimulating the growth of the functional layer, the secretion of all these particular vessels. And of course, it fools the body into thinking, oh, there is an oocyte out there that may become fertilized. But there isn't an oocyte out there that becomes fertilized. Why? Because when you have estrogen and progesterone, it already has that negative feedback very early on, which means that female individual doesn't develop any of her follicles at all, right? So because of that, toward the end of that particular time frame of whatever pills that you take, you have like a series of sugar pills or placebo pills. Now you don't have to take that if you don't want to, right? Because oftentimes when the female individual take those particular placebo pills, the pills without the hormones itself, it causes some degree of bloating. It causes, whatever, because it's just sugar pill, and it also causes water retention. So oftentimes they'll ask, do I need to take these pills? No, they're sugar pills. You don't have to take them, okay? But keep in mind that you have to track them, and the reason why we want them to take those pills is because you can track the days that you take those pills, so you know when the next cycle will start, so you can take the appropriate hormonal pills. Otherwise, let's say we have 5 sugar pills, and you're like, I don't want to take them. Okay, well, you better make sure you understand that at the end of 5 days, you have to start a new pack of hormonal pills. Otherwise, you're no longer protected, and you can't become pregnant, right? Because if she missed the first few days, then some of her follicle may already start developing. So therefore, there can be a chance of ovulation later on and stuff like that. So anyhow, with the oral contraceptive pills, very, very effective. But you have to use it. There is some degree of failure, obviously, right? There's like a 1% chance of failure, or whatever the case is, and stuff. Now they have patches, they have injection. They also have like urine devices, intra-urine devices that they implant, and that doesn't have any hormones. Some do have hormones. For the most part, they don't. So therefore, this implant goes in and it latches onto the walls of the uterus, and it decreases the degree of this proliferation, okay? It doesn't do anything to prevent the ovulation, so that female individual still ovulates. That egg may still get fertilized if you have unprotected sex. But because this functional layer is no longer as thick, therefore there's no implantation. So even if you have a fertilized egg, at the end of this cycle, it will be shedded out too. So anyway, that's the oral contraception. Now there's also another thing called the rhythm method. The rhythm method has nothing to do with like withdrawal during sex and stuff like that, so you don't ejaculate inside the female individual, contrary to popular belief, right? Because guys really don't have that good of a rhythm. if you think about it. So therefore, it's a misconception a lot of times. Some of my patients will come in and say, I've heard about the rhythm method. What does that mean? Does it mean that, the guy I'm having sex with have to pull out before he ejaculates, so that basically, won't inseminate me? So no, it has nothing to do with that. The rhythm method is a method that is implemented for female individuals that have regular cycle. Okay, that means you have a regular cycle. That means you know exactly when you ovulate and exactly when you menstruate. Okay, but if you have an irregular cycle, then the rhythm method is not for you. There's a much higher failure rate using the rhythm method. So the rhythm method basically allows you to track your basal body temperature, because when you ovulate, there's a spike in your body temperature. So basically, if you track it, there's gonna be this particular time where you have an increase in body temperature. This is due to the ovulation effect, that LH being secreted in very high amount. Right? So during that time, let's say, if I remember correctly, I believe it's like 5 days or 3 days before and 5 days after, you're not supposed to have unprotected sexual intercourse, because that is the greatest time that you can potentially fertilize that egg. Okay, so therefore, if you're using the rhythm method and if you are regular in your particular cycle, then you should not have sex within that, what we call the window of receptivity, right? Within that week, right, between the ovulation period. After that, you can. So if you want to, you can have sexual intercourse much later within the luteal phase. It's gonna be much safer that way. Okay? But if you have sexual intercourse, unprotected sex, and you ejaculate into the female individuals, let's say about 3 or 4 days before she ovulates, sperm can live inside the female reproductive tract for up to 5 days. So therefore, if you had unprotected sex and you ovulate immediately within the next 2 days or so, you can actually fertilize that egg, right, without the partner being there. Okay, so that's why the rhythm method doesn't work. Only if you're very regular and highly organized in terms of how you chart your basal body temperature, then this may work. But otherwise, no, it won't work. There's also another surgical intervention where you basically, clip the fallopian tube to prevent the passage of oocytes to reach wherever it needs to reach to. And that's obviously a more permanent thing. You can't really reverse that process as much as you can reverse the vasectomy in male individuals, right? And typically we ask the female individual ahead of time, let's say if she is going through some kind of C-section, cesarean section because of whatever reason, right? You ask that female individual, okay, well, have you thought about contraception, right? And if the female says, yeah, you know what, this is my third kid, I don't want any more kids. So one of the permanent methods, since we already opened her up, you might as well just start, cutting and clipping the fallopian tube at that point, right? It's easier that way because everything is already open. You already have the operating, theater there for you, so then you can do it, very easily, rather than scheduling her later on, so that you can open her up to basically go in there and isolate her fallopian tube, which takes, obviously there's a high chance of bleeding, infection, and things like that too. All right. Anyhow, once the female individual reaches somewhere within her mid to late 50s, sometimes even early 50s, sometimes even in her 40s, doesn't really matter, but on the average, it's going to be somewhere within the mid 50s or so, right? She reaches the age of what we call menopause. Menopause is the cessation of ovulation. So basically, at that point, she's running out of eggs to ovulate. Okay. Now, when that is happening, the patient will exhibit a series of these symptoms, like variation in irregular body temperature and stuff like that, mood swing, massive mood swing and stuff. So the patient may come to you and say, you know what, I feel like I'm at that age of menopause, right? You should ask her, well, when was the last menstrual period that you had? If she said, oh, it was like maybe 2 months ago, then she's in menopause, but she's not out of it yet, which means she can potentially become pregnant still, okay? So in order for the female individual to be in what we call post-menopausal state, as she's going through this menopause, she must have a period of 12 consecutive months without menstruation. Okay, so if she doesn't have any cycles, any menstrual cycle for 12 months or a whole year, then she is now officially in postmenopause. Okay, or in that menopause state and then postmenopause afterwards. Now, one other thing to worry about in terms of the female individual is while you're in your reproductive years, you have estrogen being secreted all the time. Estrogen is the wonder hormone. It is the one hormone that will protect you against a lot of cardiovascular diseases and cerebral diseases and stuff like that, right? So the risk factors for, let's say, male versus female for, like, you know, cardiovascular diseases and all that stuff, for the males, it's always high. And the females, it's always low during the reproductive ages and stuff like that. So let's say from 18 to about 50, right? The female's risk is always down here, whereas the male's risk, once they reach 18, boom, shoots all the way up, right? And stays elevated. But once the female individual reaches the age of menopause and beyond, her risk factor now, because she no longer has estrogen, her risk factor for cardiovascular diseases and cerebral accidents sharply increases, and it's now increased above the male counterparts. Okay? So in postmenopausal ages, things starts to happen. Okay? A lot of time it's unpleasant and stuff, so that's why we have some kind of management in terms of, like, let's say, hormonal replacement therapies and stuff like that, right, to help regulate some of those mood swings and some of those symptomatic changes that occurs. But anyhow, we don't need to really talk about that. The one thing that you guys do need to worry about, though, in menopause is the massive degree of bone loss. Okay, because estrogen is one of those hormones that help maintain the strength of your bones, adequate amount of bone tissue, okay, along with other things like parathyroid hormones and calcitonin and all that good stuff too. Okay, but estrogen also helps to maintain that. Now, if you have no estrogen, then what happens is that you will have massive degree of bone loss, and therefore the female individual, as you know, she gets older and older, has an increased risk of osteoporosis and fracture. Okay. So oftentimes, you gotta watch out for that. All right. Good. Any questions? Let's go to that.